I'd like to present some of the key messages from the recently presented and published update of the 2023, focused update of the 2021 ESC heart failure guideline. We've made some changes in the guideline to a few sections. Firstly, chronic heart failure for those patients with mildly reduced ejection fraction and heart failure with preserved ejection fraction, acute heart failure, and some changes to the comorbidity section. The main changes we've made to both mildly reduced ejection fraction heart failure and preserved ejection fraction heart failure relate to two trials which were published with the use of SGLT2 inhibitors, empagliflozin in the case of the EMPEROR preserved study and dapagliflozin, the DELIVER study, for patients who have heart failure with ejection fractions above 40%. Both of these trials reduced the primary endpoint of cardiovascular death or hospitalization for heart failure. So for patients with mildly reduced ejection fraction, with ejection fractions between 40 and 50%, we're now recommending an SGLT2 inhibitor, either dapagliflozin or empagliflozin, with a Class 1A recommendation to reduce heart failure, hospitalizations, or cardiovascular death. And similarly, for patients with heart failure with preserved ejection fraction, a Class 1A indication for both of these SGLT2 inhibitors to improve outcomes. For patients admitted to hospital with acute heart failure, we've also got some new evidence from the STRONG-HF study for optimizing heart failure therapy before discharge and then rapidly up-titrating it after discharge. So we're now suggesting an intensive phase of initiation and rapid up-titration of disease-modifying evidence-based therapy and follow-up for these patients after discharge, Class 1 evidence, level of evidence B. For patients with type 2 diabetes and chronic kidney disease, we have some recommendations now for prevention of heart failure going forward. So based on results of randomized controlled trials and meta-analyses, we have evidence for dapagliflozin and empagliflozin for patients with chronic kidney disease and type 2 diabetes for prevention of heart failure. And we also, for a similar population, have data for finerenone. So both SGLT2 inhibitors and finerenone now have Class 1A evidence for prevention of heart failure in patients with chronic kidney disease and type 2 diabetes. And lastly, we've updated some of our recommendations for iron deficiency in heart failure for the treatment of iron deficiency with intravenous iron. We've upgraded our recommendation for intravenous iron improving quality of life and symptoms to Class 1A for patients with heart failure with reduced ejection fraction and mildly reduced ejection fraction heart failure. And based on two trials, AFFIRM-HF and Ironman and meta-analysis thereof, we're now giving a Class 2A indication, level of evidence A, for intravenous iron supplementation with either ferric carboxymaltose or ferric diazomaltose to reduce hospitalizations for heart failure. So those are the key messages in a nutshell.